honor. So Dr. Fonseca is my boss, my mentor. He was my program director during Fellowship of Endocrinology. Really, when I came to the program, I was interested in diabetes, and kind of everything went from there. But he is professor of medicine. It's going to take me 5 minutes, and I'll be really short with his introduction here. But he is professor of medicine, assistant dean for clinical research, chair of diabetes and endocrinology section at Tulane. He is a past president for science and medicine of the American Diabetes Association in 2012. He has served on multiple boards of directors for American Diabetes Association, Clinical Endocrinology, Association of Clinical Endocrinologists. He was awarded a Banting Medal for leadership and services in Southern Medical Association. This is one of the kind of most prestigious awards one can get. So he's pretty much done it all. He's been editor-in-chief of Diabetes Care, really the most read diabetes journal globally, editor-in-chief of Journal of Diabetes and Its Complications. So if you have a diabetes question, he's the man to answer and point in the right direction. And in addition to all that, and it all makes sense, but his main kind of interests are prevention and treatment of diabetes and its complications, and risk factor reduction for cardiovascular disease. So I could go on for another 10 minutes, but for sake of time, Dr. Fonseca, welcome, and thank you for taking time to join us and share your knowledge about neuropathy.
Thank you very much, and I hope you can hear me okay. Thank you, Dragana, for that very kind introduction and for inviting me to do this. Dragana gave me a big challenge. Say everything you know about diabetic neuropathy in 15 minutes, and now she's cut it down to 10. So I'm going to try and do the best I can. So let's move on and try and finish this. So my objectives are to understand the clinical impact of peripheral neuropathy, which you probably know very well, talk about the symptoms and signs that you see, talk a little bit about the etiology and what we can do about it. Next slide. So, diabetes has many complications, and arguably peripheral neuropathy is probably the most common of them. If you give people enough time, and if their diabetes is not very well controlled, I'm sure you're discussing a lot of people like that, they will slowly get some neuropathy, and over time that manifests itself. And you see a lot of variation in the literature about how prevalent it is. It depends on how you make the diagnosis and what criteria you use. So let's talk about that. Next slide. So up to 70% of people with diabetes will lose some sensation in their feet. It's a question of how you test for it that really matters. And I'll elaborate on that as we go along. Next, click. Okay. And approximately 25% of those people will get some kind of foot ulcerations. And here you see the worst form of foot ulcerations. That's very common. The patients can't see it themselves, and unless you look for it, you might miss it in the early stages. Callus with a deep penetrating ulcer. Next slide. And then this unfortunately ends up with amputations. And many people with an amputation often have a second amputation. Mortality rates in this population is very high, and just managing them is challenging. Next slide. So what do we mean by diabetic neuropathy? Basically, the simplistic terms, it's nerve damage or dysfunction secondary to diabetes. It doesn't matter what type. And the general consensus, if a patient has symptoms and or signs, then you exclude other causes, then you make a diagnosis of neuropathy. So sometimes people just have symptoms. So there are various types of neuropathies. It's not one single thing. The commonest things that we see is the sensory motor polyneuropathy, the typical glove and stocking, loss of sensation with some muscle weakness. But occasionally you get proximal motor neuropathy, which is more in the femoral nerve. So you get thigh weakness, or in the truncal neuropathy. Also, very interesting sometimes is the mononeuropathy. So you get single cranial nerve paralysis, sometimes multiple nerve damage. And then you get autonomic neuropathy, which is to me the most serious form of neuropathy that's often neglected because we don't test for it very often, but it causes the patients a lot of distress. Postural hypotension because of autonomic neuropathy, gastroparesis, diabetic diarrhea, bladder dysfunction. So you get a lot of autonomic symptoms that people complain of, dizziness, and we can't find anything. And it may be that we are not checking for postural change. Next slide. So what's the impact? As I pointed out, lots of foot ulcers, lots of amputations, and diabetes is the most common cause of non-traumatic amputations in this country. The amputation rate had fallen. It had really dropped. It was very interesting, but it seems to be creeping back up again. And some of the drop related to better foot care, but I think we shouldn't let our guard down. We need to pick up things like this, a nail in somebody's foot, and he's got no sensation, so you miss it, and patient doesn't complain about it. So just taking the shoes off can sometimes reveal horrible things like this. Next slide. So there are a lot of unmet needs here. There's a wide range of treatments for pain, but no real treatment to treat the neuropathy. People make the mistake of thinking, well, I've given this patient's got neuropathy, I gave him gabapentin. Well, you're treating the pain, but you're not treating the neuropathy. And for that, the only real treatment is essentially the better control, glycemic control. There have been a number of drugs that have become available to help with pain. Unfortunately, nothing has made it that will really improve neuropathy, except for one or two things that I will talk about. So our aim is to keep people comfortable, but actually try to prevent the progression of the neuropathy. Now, some people make a distinction between motor, sensory, and autonomic. Very often you get a lot of overlap. The motor neuropathy is mainly muscle loss and muscle weakness, which is important because it leads to foot deformities. And so the shoes that are standard don't kind of fit the patient very well. So it is actually quite important to test for motor things. But the important thing is really the sensory loss. And that can be touch, vibration sense, thermal sensation, whether it's hot or cold. And it depends on the type of fiber that's affected. And as I pointed out to you, autonomic neuropathy, which affects the heart rate, the blood pressure, the sweating in the skin, which leads to dry skin and ulceration. And actually, I want to point out a very interesting finding in few studies that a high heart rate due to autonomic neuropathy is a very important predictor of sudden death because if people have high resting heart rate, it often indicates loss of parasympathetic control. Next slide. So what tools do we use? And I'll start at the bottom with something we shouldn't often need to do, and that's nerve conduction velocity. If you go to a neurologist, that's what they do. But I rarely ever do it, except when the pattern doesn't fit. If a patient has one-sided sensory loss, that's not typical. So I want to make sure there's no compression. That's when I ask for nerve conduction velocity. The earliest abnormality that you find is a loss of sensation, of vibration sense. So I think having a tuning fork, if you really want to make a diagnosis early, is useful because you may have no other sensory loss in the early stages. Now, there are ways to quantify that, and you see a picture there of a thing called a biothesiometer. I don't recommend it. It just adds to your cost, and it's not really reimbursable. And another thing that is very common is the monofilament. It's just like a little bit of plastic, like a fishing line. It's standardized, the Semmes-Weinstein monofilament, which is actually developed in the leprosy center at Carvel, Louisiana. So a very big export of Louisiana to the rest of the world is in this particular area. And the importance of the monofilament is not to diagnose neuropathy. You can diagnose it with a tuning fork. It's to tell you that the patient has lost sensation. And if you've lost sensation to the monofilament, your risk of amputation goes up. So that tells me immediately this patient is at risk for amputation. This patient needs additional education, needs special footwear, which, by the way, Medicare pays for routinely and is probably the biggest way of reducing the risk of amputation. Next slide. So here's the impact. You have pain as a major symptom. It affects quality of life. That's what used to bring, and probably still does, brings people to the doctor. They're less likely to complain of sensory loss, but actually that's the most dangerous. So the pain is not dangerous. In fact, some people get severe pain and then they get worse and the pain goes away because they lose even pain sensation and they think they're better, but actually they're worse because now they're at risk of amputation. And that's when you get the damage to the foot, which they don't feel. And you get the foot ulcers, the infections that trickle down to the bone, and you end up with osteomyelitis needing amputation. There's also a thing called Charcot foot, which is loss of the structure of the foot, and that too contributes to amputation and then ultimately mortality. So if you draw the distinction between large fiber and small fiber, you don't often have to do that. In large fiber, you lose a lot of vibration sense. People get numb. They have wasting of their muscles, and the foot tends to be actually warm, and there's a risk of Charcot neuropathy. Next slide. And small fiber is, you get a different kind of pain. It's very severe, burning, superficial pain. Allodynia is when the patient cannot stand even the bedclothes being on top of their legs. They're very sensitive to pain. And that's actually a very distressing to some patients. Next slide. So you also get loss of heat sensation. Some people burn themselves. They don't feel the pain. They don't sweat. So the skin gets dry. And they might have normal reflexes, normal EMG. And people often miss this. I don't recommend skin biopsies and quantitative testing, but it's done by some people. And in contrast to the other type, the foot tends to be cold and people at risk of gangrene and amputation. Next slide. Let's move on. So what do we do? What do we tell patients? Management means education, getting people to wear padded socks, the appropriate footwear, which can be prescribed. So you can write a prescription. Look at the patient's feet at least once a year, or maybe 2-3 times a year. And you can even give the patient a monofilament. There are actually some kind of things where, you can go to a pharmacy and stand on a thing. It'll tell you whether you have abnormal pressure on a particular spot. That's where your patient needs some kind of protection, some kind of molding to protect them from getting that skin from breaking down there. They need to be careful about exposure to heat injury. And they should use creams to avoid the dryness, which is a sympathetic dysfunction, so that the cracks in the skin don't let the bugs in. Next slide. So this is a study showing simple intervention. Just telling your patients about these things will reduce the need for foot ulceration and amputation by almost 50%. And just providing people with this kind of simple things like a mirror on the look at their own underneath of their foot and giving them a monofilament might make a huge difference at very little cost. Next slide. You need to talk to people about the sensory loss, which is very important, and try to alleviate their pain, obviously, but bear in mind that that's not just they are not treating the neuropathy. Next slide. So we want to halt the progression, and for that you need good glycemic control. I cannot emphasize this more. People actually do get better when the A1C drops from 9 to 7. They will feel better in a few months. It doesn't happen immediately. Another thing that's often forgotten is there are other causes that might make it worse, and one of them is B12 deficiency, which is quite common in this population due to autoimmune disease, but also metformin leads to B12 deficiency. So we have done studies with high-dose vitamins and showing improvement in patient symptoms. Next slide. And these are the kind of treatment management options. Obviously, glucose management, which you've been discussing, and pain management. Although you're not treating the neuropathy, you don't want your patients to suffer. And there are a wide variety of agents. The only two that are actually approved by the FDA are duloxetine and pregabalin, but they are a bit more expensive and there are alternatives. So gabapentin is not approved, but it's very similar to pregabalin, and I use a lot of gabapentin. Instead of duloxetine, you can sometimes use amitriptyline, but it can make autonomic dysfunction worse. You need to be aware of it. Some people respond to clonidine in the form of patches, and for very severe pain, some people do prescribe opioids. It's very much out of favor today, but does that mean we let our patients suffer? And I've had patients who've previously been going to pain clinics now come crying to our clinic saying they can't do without their opioid. And it's a very distressing situation. So what is needed is total symptom management while you're working on the glucose management, looking at other alternatives. So I mentioned the B12. There's actually some studies with alpha lipoic acid, which is an antioxidant available without a prescription, that has helped people in some clinical trials. And so it's not getting pushed by anyone, but it's available and it has had positive clinical trials. So you can use a kind of global approach here to try and get people's diabetic neuropathy improved while hopefully preventing amputations with the appropriate footwear, and so forth. Thank you.
Great, thank you, Dr. Fonseca. We'll see if anybody has
Thank
any
you.
questions. But thank you, this was a great lecture, and I think topic that's really not covered well in any field, in any conferences. This is really under kind of estimated. I think also independence, right? If you have a foot ulcer, you can't walk, you don't have your independence, you may not be able to drive, and so on. I think our podiatrist is smiling because now we're all ready to examine feet all day. Okay, so anybody has any questions for Dr. Fonseca?
That was thorough. That was so great. We appreciate it.
In only 10 minutes.
I know. I feel so bad. I do have one question, Dr. Fonseca.
Okay, go ahead.
With the vitamin B12, this guy, for example, the patient case, maybe you didn't hear the whole thing, but he's had diabetes since 2000. And he's been on metformin. And so a lot of people are started on metformin. Do you routinely check the levels if it's been a few years on metformin?
That's a very good question. I generally feel that it's measuring B12 itself is not very useful, at least from our own studies. Methylmalonic acid is a better test. However, you don't need to do it. If your patient is on metformin having symptoms, there's no harm in trying some B12, but an over-the-counter multivitamin is not going to help. You actually need higher doses of specific B12. There are a couple of prescription-based multivitamins like Metanex, but those cost a lot of money. If your insurance covers it, that's fine. There are some generic equivalents for it, but you do need to give the higher doses to get symptom relief in the near term. That is, to me, in our study, we found the only thing that I've seen that improves sensory loss. Pain relief doesn't improve sensory loss, it improves pain. So gabapentin and drugs like that will not help you get your sensation back.
Okay, so get their diabetes under control and then have them take some vitamin B12. And especially in cases where they can't afford to get a level that might cost $200 to go to the lab. I mean,
another thing that I think is really very sad. We write the prescription for the shoes, the patients get the shoes, and the patient doesn't wear them. Why?
Yeah.
Because they don't look nice. Well, when I tell them that it costs almost $1,000 for Medicare to give you those shoes, maybe they sometimes will wear it.
Yeah, that's true. Okay, great. Anybody else, any questions? Otherwise, I know it's 1:05, so
what dose
go
of
ahead.
B12?
That is not worked out. But the doses we used in our study, Metanex, were very high. But that doesn't mean you have to use that. I think the simple over-the-counter one doesn't work. I mean, most of our patients were taking that in the control group.
So a little bit higher.
It does
okay.
A little bit higher. Okay.
Okay, great. Well, thank you again, Dr. Fonseca. It was very nice having you. Thank you, everyone.
Thank you. Thanks for inviting me.